Good morning, good afternoon, and good evening. Wherever you're joining from, welcome to this webinar. It's great to see such a broad audience for what is a very timely topic. My name is Martin Christensen, and I'm representing Hamamatsu Photonics Europe. While we are hosting today's session, the focus is very much on scientific work and real-world experience. Today's webinar centers on a study exploring the use of whole slide imaging in cytology for primary diagnosis, looking at concordance, workflow considerations, and how digital performs across different specimen types in routine practice. With me today, I have Dr. Sabine Pomplun and Dr. Adam Levine. We're very pleased to be joined by these two highly experienced experts. Dr. Sabine Pomplun is a consultant histo-cytopathologist at the University College London, bringing over 25 years of experience in diagnostic cytology. Her contribution to this study focuses on identifying practical diagnostic challenges and pitfalls while transitioning to digital reporting. So a very grounded and real-world perspective. Dr. Adam Levine is the senior pathologist at Hadassah-Hebrew University Medical Center and affiliated with the University College London. He works at the intersection of diagnostic pathology, AI, and genomics, leading research in image and data-driven approaches. So to this study, he brings a complementary forward-looking dimension to the work. What makes this study particularly relevant is that it evaluates digital cytology in a diagnostic setting across multiple preparation types, highlighting both where it performs well and where careful consideration is needed. During today's talk, you will hear Hamamatsu products featured. While the study focused on the NanoZoomer S360, the findings allow us to expand the intended use for the whole NanoZoomer MD series in Europe. That can now be used to acquire digital images from a broad range of cytology preparations, including conventional pap smears, liquid-based cytology samples, non-gynecological preparations, and fine needle aspirates. With that said, we'll begin the presentation, followed by a discussion and a Q&A. So please do feel free to put in your questions during the session, and we'll do our best to answer them either now or after the call. We'll pick up as many questions as we can during the sessions, but the rest we'll continue on answering after the call by email. With that said, Dr. Pomplun and Dr. Levine, the stage is yours. Please take it over.
Thank you very much, Martin. I will just share my screen. Is that sharing for you?
Yes.
Great. Okay, so thank you very much for the introduction, Martin, and it's a pleasure to be here today to present the work that we've done assessing the use of digital scanning of cytology images for primary diagnosis across a range of specimen types. This work was done between UCL and University College London hospitals in London in the UK. The work that I'm going to present today is largely based on our publication in the journal Cytopathology, which came out earlier this year. To begin with disclosures, Hamamatsu provided funding to support the study, but had no role in selecting the cases, undertaking case review, diagnosis, analyzing the results, or drafting the manuscript. And we and our co-authors have no other conflicts or disclosures to declare. So first, a little bit about the current revolution in digital pathology that we are in, which I'm sure many of you are well aware of. Historical pathology being focused on examination of gross specimens and light microscopy transitioned through a big revolution with the introduction of immunohistochemical techniques, molecular pathology, sequencing, FISH, whole genome sequencing approaches. And more recently, the current revolution sees us enter the digital age, in which slides are scanned with high throughput, high resolution scanners. And rather than viewing the glass slide down the microscope, we view the image on a computer monitor. This affords numerous benefits, including improving the workflow, facilitating remote reporting, case sharing, annotation of slides. It facilitates archiving of digital images, enabling easier case review of historical cases. And importantly, having the images in a digital format enables computational image analysis and artificial intelligence, which we are already seeing enter the clinical sphere and will increasingly become more common and more adopted with time. To support the use of digital pathology, there's a strong evidence base which has arisen through numerous publications comparing the concordance of light microscopy and whole slide imaging in histopathology and surgical pathology specifically. And these studies have demonstrated high concordance, supporting confidence in the approach and enabling regulatory approval to be obtained for the scanners and for the approach in general. And through this evidence base, we've seen a widespread and increasing adoption of digital pathology in routine practice across institutions and geographies. This has been increasing over the recent years and ultimately is leading to enhanced diagnostic efficiency and patient care. It's worth saying that this general description I've given here is really predominantly about surgical pathology and histopathology and not about cytopathology. So what is cytology, cytopathology, and how does it compare? Again, things that I assume will be familiar to most of the audience. Cytology plays a vital role in diagnostic pathways and involves the assessment of exfoliative fluid, FNA samples, and other types of preparations from a variety of specimens, pathologies, including bodily fluids, pleural effusions, acidic effusions, urine, fine needle aspirates as shown, brushings, cervical smears, and so on. There are important key distinctions between the laboratory aspects of histology and cytology, and these have important implications when we come to think about digitization. So whereas histology involves fixation of the tissue, embedding and sectioning to 3 to 5 microns, generating a single thin section, in cytology, a variety of preparation methods are used. These include smears, the conventional historical type of cytology, cytospin preparations, and liquid-based ThinPrep, for example, preparations. Each of these has some complications when it comes to digital pathology. The smears often have variable thickness. They can show air drying artifact and fixation variability. The cytospin can involve the material being concentrated in a small area but being variably distributed across the pellet space. And ThinPrep or liquid-based preparations deal with some of the variable thickness seen in smears and are advantageous in that way, but can still be associated with some variation and low cellularity. The variability seen in cytology preparation can impact digital standardization and image quality. Specifically, the thickness of the smears and the 3D clustering that can be seen can be challenging where scanning a slide in which we normally expect and want to see a single focal plane as we would expect with histology. Some of these challenges have resulted in there being perhaps limited validation studies and publications in this space as compared with histopathology and surgical pathology. And while there is an increasing number of such publications, we found at the time we were beginning this study that there was really a lack of studies that looked across multiple specimen types and preparations. Many studies focused simply on one type, and that breadth of sample preparation and type was important when we think about validating a scanner for use in diagnostic practice. So coming to our study design, this was a single center retrospective diagnostic validation study aiming to evaluate the use of the Hamamatsu 360 MD slide scanner system. We looked at a range of specimen types, preparations, and diagnoses representative of common daily practice in our hospital. That included both gynecological and non-gynecological fluid specimens, direct smears, cytospin, and ThinPrep preparations. The primary objective of the study was to determine the level of diagnostic concordance between high-resolution whole slide images and traditional light microscopy across a variety of cytological specimen types and preparations. And the secondary objectives were to assess the quality of whole slide images and qualitatively determine are cytopathologist attitudes and experiences of reporting cases, cytopathology cases digitally. So the study overview is shown graphically here. We had 2 general cytopathologists and 2 gynecological cytopathologists. The reason for that distinction is in the UK, reporting of gynecological smear preparations, samples is separately regulated and accredited to general cytopathology. We had 83 specimens falling under the general category and 5 gynae specimens. The general specimens were a mix of smears, ThinPreps, cytospins, and cell blocks, and the gynecological preparations were all ThinPrep based. The cases were examined via light microscopy and by digital cytology through methods I'll go through shortly. And we went on to then perform concordance, agreement analyses, consensus meeting reviews, and so on. In terms of the cases and their distribution, these were historical cases, mainly from 2023 to 2024. They were selected from each of these categories based on the original GLASS diagnosis to reflect common findings for each specimen type and preparation, including negative diagnoses. And importantly, the GLASS slides were not reviewed prior to ascertaining whether a case would be included in the study. And that was to avoid bias in selection of cases that were particularly challenging or easy. You can see here that the categories include pretty much all of the main body systems, gynecological cervical brushes, ThinPrep, 5 cases, respiratory, including sputum, salivary gland FNA, and bronchial brushes of various types, and numbers as shown here. For each category examined, there were at least 4 cases, a minimum of 4 cases, and in total, we had 88 cases. The samples were from patients with a mean age of 56 years, slightly more female than males, and the breakdown of preparation types is shown here: 36% smears, 31% ThinPreps, 28% cytospin, and a small percentage of cell blocks. In total, we had 205 slides across these cases with a mean of 2.3 and a median of 2 slides per case, ranging from 1 up to 13. The slides were stained with MGG staining or Papa-Nicolau staining in most cases, and a smaller number for the cell blocks were stained with H&E or immunohistochemistry. 24 of the cases had at least 1 MGG and 1 PAP stain slide. 31 had MGG only, and 29 had PAP stained only. In terms of the slide scanning, all of the slides from each case were retrieved from our archive. The slides were cleaned to remove dirt, fingerprints, pen markings, etc. And the slides were then scanned using the Hamamatsu NanoZoomer S360 MD slide scanner system, generating NDPI files. Slide acquisition was undertaken at 40x, equivalent magnification corresponding to corresponding to 0.23 micrometers per pixel, and image acquisition was undertaken with the NZ-Acquire MD software. For slide scanning, the semi-automatic scanning function was used, in which the slide is first scanned at low power, and then focal points are identified and placed on the slide automatically, and these can then be adjusted as required in a manual step later. The scanned slides underwent manual quality review and were rescanned if required, and slides were subsequently anonymized using Hamamatsu's NZ mask software before being transferred for reading by the study pathologists. The digital reporting involved each case being reviewed by 2 Royal College of Pathologists certified cytopathologists. Our reporting pathologists had between 8 and 35 years of consultant experience. We had, as I said, 2 different pathologists reporting the gynecological cervical cytology cases because of the separate regulation of that in the UK. The cases were examined using either a 31.5-inch 8 megapixel monitor or a 16-inch 4 megapixel monitor using the NZView MD software. The cytopathologists were given the same clinical information as was available at the time of the original reporting, including the patient's sex, age, specimen type, and clinical history. And they were blinded to the original light microscopic diagnosis and whether additional work, such as immunohistochemistry, cytochemistry, cell blocks, and so on, were undertaken on the case. Discordance between the original light microscopic diagnosis and the digital diagnosis was identified and was characterized as such if either or both of the study pathologists had a different diagnosis between the original light microscopic and that digital diagnosis. And under such cases of discordance, the case was reviewed by light microscopy by both the study pathologists and then discussed at a consensus meeting. If either one or both of the reviewing cytopathologists' light microscopic diagnosis was discordant with each other and or the original light microscopic diagnosis, the case was defined as a case showing diagnostic discrepancy by light microscopy. In other words, a case with diagnostic uncertainty. And this was classified for any cases of discrepancies with a potential impact on clinical management. And we felt that these cases reflect cytopathological cases with intrinsic diagnostic ambiguity. So showing the flow of cases through the study, as I said, we started with 88 cases, of which 83 were non-gynecological and 5 were gynecological. These cases were each examined by 2 study cytopathologists, and the diagnosis from the digital examination was compared to the original light microscopic diagnosis. In 65 of the 88 cases, there was concordance between the digital and original light microscopic diagnoses. And in 23 cases, there was discordance between either one or both of the digital and original light microscopic diagnoses. And these 23 cases were then examined by light microscopy, again by both study pathologists, and a consensus meeting was held. And as I described the definitions as per the previous slide, we defined 8 cases as having no diagnostic uncertainty and 15 cases as having diagnostic uncertainty, which I'll go into explain more now. So these are this is a list of the 15 cases showing diagnostic discrepancy by light microscopy. So this is where there was no consensus between the original and the review light microscopic diagnoses. So you can see here the category of the specimen, the original light microscopic diagnosis, and then the 2 study pathologists' light microscopic review diagnoses. So this was only examined for the cases which were discrepant by digital to light microscopic comparison by at least one of the study cytopathologists. So picking out a few examples here, you see, for example, this case was diagnosed, bronchial brushing, originally diagnosed as adenocarcinoma. When our study cytopathologist reviewed that light diagnosis, they actually saw no malignant cells, whereas the second study cytopathologist also called it adenocarcinoma. So clearly this is a difficult case, perhaps with very sparse cells or on the border of atypia, malignancy, where the call as to whether it was malignant or not was challenging. And there are further examples along those lines, nipple discharge being C3 likely papillary, complex nipple discharge not discordant, but then also being called a simple nipple discharge C2. If we look at the 8 cases where there was no diagnostic uncertainty in the light microscopic diagnosis, but there was potentially discordance in the digital diagnosis, we can see a variety of outcomes. So for example, a common bile duct brushing, the light microscopic diagnosis was a consensus diagnosis of negative for malignancy. One cytopathologist digitally agreed that that case was negative for malignancy, but the second cytopathologist observed there to be atypical cells present. Another interesting example, a pleural fluid, where the light microscopic consensus diagnosis was lymphocytic effusion, but by digital, one of our cytopathologists thought that there was evidence of small cell carcinoma. Here we've also shown that in some cases, the cytopathologist felt that the digital preparation was too thick and deferred to glass. I'm now going to take you through three of those, three examples of those cases from that previous table. So this was a case of a lymph node, FNA, the original diagnosis, and consensus light microscopic diagnosis was non-necrotizing granulomatous inflammation. One cytopathologist by digital analysis agreed with that, whereas the other called it inflammatory without observing those granulomas. And we can see in these images that there are indeed clusters of epithelioid histiocytes. However, these were quite sparse on the slide and potentially could have been missed on digital review. And in some cases, it could be arguable whether this is sufficient itself for a diagnosis of granulomatous inflammation, this loose small aggregate. In this case, I mentioned already a pleural fluid consensus diagnosis of lymphocytic infusion, where one of our cytopathologists on digital diagnosis raised the possibility of small cell carcinoma. Representative images shown here, a challenging area diagnosing between lymphocytic effusion and small cell carcinoma sometimes. Interestingly, in this case, the patient subsequently had a biopsy which demonstrated a small cell carcinoma. So it's possible that all along this was a small cell carcinoma, although we cannot prove that in retrospect. And then the final case example here, common bile duct brushing, where the consensus light diagnosis was negative, and one cytopathologist felt that there were atypical cells present. Some example images shown here. Again, this is an area in cytopathological practice, which is quite difficult and perhaps subjective as to when you call something atypical, when you call it negative. Cases showing diagnostic discrepancy by light microscopy and/or discordance occurred in all specimen types and preparations, except for cell blocks and synovial fluid. There was a greater frequency, at least 2 cases, seen in several categories: nipple discharge, cervical brush, lymph node, common bile duct brushing, breast FNA, urine, and sputum. In the majority, 3 of the 4 cases in which the cytopathologist deferred to glass, they were smear preparations. And some, but not all of the discordant cases were noted to be porcicellular, thickly spread smear preparations with 3D clusters of cells that were difficult to visualize. Importantly, however, the sample sizes were too small to make a definitive assessment of the relationship between the quality, diagnostic ability, and specimen type or preparation. In terms of the concordance analysis, 3 different calculations were performed. The first excluded cases showing diagnostic discrepancy by light microscopy, and this was on the basis that such cases show diagnostic uncertainty by light microscopy alone, and therefore could confound a digital light microscopic comparison. The second 2 concordance calculations included those cases showing diagnostic discrepancy. One was an internal concordance in which the digital diagnosis was compared to each cytopathologist's light microscopic review diagnosis. And the third was a majority analysis where the digital diagnosis was compared to the majority light microscopic diagnosis from the 3 reviews, the 2 reviews and the original. Cases with no agreement between at least 2 of the 3 light microscopic reviews were excluded. And for each of the 88 cases, concordance comparisons were undertaken independently for the 2 cytopathologists. So here showing the 3 concordance calculations, concordance calculation 1 using these 65 cases, and concordance calculations 2 and 3 including the 23 plus the 65. And the results are shown here. So each of those 3 calculation methods, whether or not cases of diagnostic discrepancy were included or excluded, how the method of comparison of concordance, and the results. And you can see that 95.1% concordance was achieved when diagnostically discrepant cases were excluded. When they were included, it was between 89.5 and 89.8, depending on exactly how the ground truth was, light microscopic diagnosis was determined. We went on to compute an agreement analysis using Cohen's kappa, in addition to the percentage concordance comparison. To do this, each diagnosis was recoded into a diagnostic category. So rather than using the actual diagnosis, we categorized each diagnosis into one of defer, inadequate, negative/inflammatory, benign, atypia, suspicious, and malignant. Using these reclassifications, agreement was assessed using Cohen's kappa with 95% confidence intervals calculated. And this was done both in an unweighted and a weighted method. With the unweighted, we assumed, we looked at exact categorical agreement, negative inflammatory with negative inflammatory, atypia with atypia. Whereas in the weighted, we account for the ordinal nature of diagnostic categories, whereby there is a trajectory between benign, atypical, suspicious, and malignant. In this analysis, larger diagnostic discrepancies are penalized more heavily than adjacent category disagreements. So between suspicious and malignant is less of a severe distinction than between benign and malignant. To do this, we had to collapse benign, negative, and inflammatory into a single benign category to reduce the to improve the stability of the calculation because of the number of categories. And this also reflects similar clinical implications, distinguishing between inflammatory and malignant. Analyses were performed on a pairwise basis for each cytopathologist, and because the gynecological cytology cases were reported by two different cytopathologists as the rest of the cases, they were excluded. The results of the agreement analysis are shown in this table, unweighted and weighted, and including and excluding cases with diagnostic discrepancy by light microscopy. You can see here the intra-observer between digital and light microscopic analyses comparisons for cytopathologist 1 and 2, the inter-observer comparison, so cytopathologist 1 versus cytopathologist 2 light microscopy, and the inter-observer digital cytopathologist 1 versus cytopathologist 2 Cohen's kappas with 95% confidence intervals. As you can see, in general, the kappas are high. The kappas increase as cases with diagnostic discrepancy by light microscopy are excluded. And they tend to also increase as cases are weighted versus unweighted, as would be expected. Summarizing some of those agreement analyses results, in general, there was high intra-observer agreement between digital and light microscopy for both cytopathologists with kappas between 0.83 and 0.95. And that, as I said, that intra-observer agreement improved following the exclusion of cases showing diagnostic discrepancy by light microscopy to 8.9 to 0.97, sorry, 0.89 to 0.97. The inter-observer, digital, or light microscopic agreement was lower than the intra-observer, digital light microscopic agreement, 0.71 to 0.82. And this improved, again, following exclusion of cases showing diagnostic discrepancy by light microscopy, but remained still lower than the intra-observer, digital to light microscopic agreement. So inter-observer agreement, digital light microscopic, was comparable to or exceeded inter-observer agreement within each modality. This is an interesting finding and indicates that the digital light microscopic discrepancies primarily reflect interpretive variability rather than modality-specific effects. And this conclusion of the results is supported by the consensus meeting findings, where it was felt by the study pathologist that the morphological features required to achieve the light microscopic diagnosis were visible in the digital images, and the discrepancies were primarily attributed to interpretation of those images rather than limitations in the image resolution or scan quality. Coming on to the experiential feedback aspect of the study, in general, the reporting study pathologists found it to be a positive experience, and it's important to note that the study pathologist had very limited prior exposure to digital cytology. 3 of the 4 had never reported digital cytology cases before, and all were working in a hospital that at the time was not digital for histology or surgical pathology either. Looking at image quality and visualization, all study pathologists felt that the images were acceptable for diagnostic purposes and were largely of good or excellent quality. There were occasional reports of blurry or out of focus areas, and challenges were described relating to visualization, but these included difficulty assessing thickly spread smear preparations, three-dimensional clusters of cells, and identifying sparse atypical cells, things we would expect based on our knowledge of cytopathological diagnoses by light microscopy. In terms of navigation, ergonomics, and usability, the digital viewer was considered easy to use, adequate, and responsive. There were no descriptions of lag or pixelization. There were some difficulties described with navigation in relation to scanning the whole slide digitally, and this was particularly an issue perceived for the gynecological or cervical cytology cases. These are screening rather than diagnostic in their nature, and require every cell ultimately to be examined. And that regimented examination on a digital environment was felt to be cumbersome and time-consuming as compared to doing it by light microscopy. Although it's important to note that in the UK, gynecological cervical cytology cases are pre-screened before they get to the reporting cytopathologist, and also that some of that lack of familiarity with the environment of the digital reporting system could account for that, and with experience it might improve. In terms of diagnostic confidence, the study pathologists reported moderate confidence with their digital diagnoses, although all reported greater confidence using glass, which is understandable given their history of long-term reporting by glass and short-term exposure to digital. In terms of suitability for different workflows, I've said that there were perhaps some challenges described associated with screening slides, particularly for gynecological cervical cytology. This could be addressed with pre-screening, as is done by glass, or by review by AI to first identify cells of concern. In general, there was broad openness to considering the adoption of digital cytology for primary diagnosis and second opinions. Our study had several limitations that are worth noting. I've already said that the study cytopathologists had minimal or no prior cytopathology reporting experience, and UK guidelines stipulate that a monitored period of double reporting of digital and glass is required for training, and that no doubt would change experiences, perceptions, diagnostic capability. The study design was not entirely reflective of routine clinical practice for several reasons. The study pathologists were encouraged to give a definitive diagnosis based on their interpretation of the digital slide. They had lack of access to real-time radiological or clinical data. Further testing, such as immunocytochemistry, was not possible. Rescans were not possible. Second opinions were not possible. In many cases, with a challenging cytological diagnosis in real-world practice, our cytopathologists would show that to a friend and discuss together how best to proceed with that case, whereas here our study pathologists were siloed and forced to work in isolation. And finally, there was a possible Hawthorne effect, whereby by being in a study assessing concordance, their behaviors could have changed in certain ways. To achieve a breadth across multiple specimen types and preparations, we necessarily had to limit the number of samples per specimen type, and that meant that we were not able to analyze whether there were really statistically significant relationships between sample preparation type and outcome. We also did not collect data on reporting times and workflow, which could have big implications, particularly the screening of those gynae-cytological cases were noticed to take quite a lot of time. Although again, we would expect that with training and greater exposure, times would reduce. Finally, we did not formally assess the role of Z-stacking. Z-stacking involves taking multiple scans of a slide at different focal points, enabling, but theoretically, the issue of 3D clusters to be partly addressed. Although we formally did not address that, we did test a few cases, which perhaps we'll discuss in the Q&A a little bit later, and found it to be challenging and debatable as to how beneficial it would be. To come to the conclusions, ultimately, we felt that high-resolution digital cytology achieves a strong diagnostic concordance with conventional light microscopy across a wide range of specimen types and preparations. Numerically, that was 95% in cases not showing diagnostic discrepancy by light microscopy, and 90% including those cases. And based on that percentage concordance and the number of cases assessed, we achieved the CAP validation benchmark. Despite limited prior experience, digital diagnosis proved feasible and acceptable to our study pathologists, and we felt that most discordances were attributable to interpretive rather than technical factors with the image itself. The digital light microscopic agreement is comparable to inter-observer agreement within each modality, so the observed discrepancies are therefore reflective of intrinsic diagnostic variability rather than modality-specific effects. We did note some challenges with smear preparations. There are various things that could be done with to overcome this, perhaps considering a change to liquid-based cytology, or deferring to glass always remains an option. It could also be the case that in those smear preparations with thick groups that are difficult to visualize through, even by light microscopy, those would be challenging. Our findings support the integration of digital pathology into routine diagnostic workflows, provided there is adequate training and quality assurance. Ultimately, there will likely be ongoing optimization of scanning protocols, specimen preparation, and the use of advanced computational tools such as extended focusing could help enhance diagnostic reliability. The adoption of digital cytology establishes the foundation for the application of AI to assist in screening, triage, pattern recognition, and helping pathologists be more efficient and accurate in their daily work. Further work is required in this space to evaluate training effects, the effects of digital cytology on workflow times, and the use of AI-assisted screening in a prospective setting. Just to summarize, this was our study design and those key figure headline numerical outcomes. I'd like to acknowledge our reporting study cytopathologists from University College London Hospital, our research team who collected the slides, scanned the slides, managed the data, and so on. The UCLH Biobank for Studying Health and Disease kindly provided the material needed for this study under their ethical approval. And our funders, the Gene Shanks Foundation, Pathological Society of Great Britain and Ireland, and Hamamatsu. With that, I'd like to finish the presentation and happy to open the floor to questions.
Thank you, Dr. Levine. That was a truly insightful presentation. I really liked how you looked at the whole chain of digital cytology, although, as you mentioned, it wasn't quite a real setting as there was forced decisions. But I liked really how you summarized both the positive and the negative parts of employing cytology as a digital regime. So just like to get the floor started by exploring a few aspects of your findings a bit more in detail. So one of the things that I was wondering here with doing the study and have looked at all of the results, are there any key takeaways that you think the audience should take away from this study or from your presentation in particular?
Sure. Martin, maybe I'll stop sharing my screen if you think that's best. What is your else?
Please do leave it here. It's okay. Well, I can share mine if you want.
Okay, we can leave this up. Let me just move some things around here. Sorry, bear with me a moment. Yes, okay. Sorry, you're asking about key takeaways.
Yes.
So I think there are a few. The one would be that for the vast majority of cases, digital is just as good as light. There are cases in which we found it to be difficult, but we feel that those cases probably would have been difficult by light microscopy by themselves. And the digital is not necessarily what's making those cases difficult. They're just difficult, challenging cases that require discussion amongst colleagues and so on. But really, most cases are I think, are simple to diagnose digitally and ready to go, and our data demonstrate that.
So these difficult cases, I'm in the presentation, you did mention some difficult scenarios like smears and 3D clusters. I assume those are some of the difficult cases that are slightly more challenging than others. I'm curious, here in this case, we discussed them, but did you find any tools, any tricks to effectively work around them while doing the study?
I think perhaps that question is maybe better addressed by Dr. Pomplun, if I may. Sabine, or what are your thoughts?
Yes. So thank you for giving me the opportunity to answer this difficult question. I think in cytopathology, we all know that there are these very challenging cases, and there are just clusters of cells that you cannot look into, even with light microscopy, even if you can, focus up and down. The literature sort of suggests that Z-stacking might help in this case. And Adam alluded to that, we had a few cases where we tried Z-stacking and we found that actually it doesn't improve the visibility of these groups. So I think that is a limitation in the preparation of cytology samples rather than a limitation of the modalities, because these cases were difficult to assess on light and digital pathology. Yeah, that's what I would think about these.
It's actually quite interesting you should mention that. So in terms of digital, there's often a discussion of replicating light microscopy, but you alluded to a little bit here of changing preparation. Is there any preparation aspects that could be taken into account to make it easier to scan or review that would make a difference? I know it's a bit atypical to talk of changing protocols.
Yes, yes, absolutely. So I think what we found is that the single cell layers like cytospins, ThinPrep, very thin smears, they're a lot easier to assess. I mean, that's true for light and digital pathology. And the samples that were more difficult to are the FNAs that are usually just spread directly onto the slide by the radiologist or whoever takes the FNA sample. And they're obviously a little bit thicker or sometimes contain mucus or something. So there are things that you could do. You could change your technique. You could actually just put them all into a pot of normal saline and then spin them down and do a ThinPrep preparation of that. That would actually change we would have then to change the stainings. We would then have to go to a PAP because these are then changed into fixed material rather unfixed material. But it's doable, and I know that a few other trusts already do that. They have a three-pronged approach, so they do direct smears, thin preps, and a cell block. And that's certainly something that we could look into adopting as well, and then we can sort of very thoroughly assess these samples. And also there's the possibility of mucus-solving reagents that you could add to bronchial lavages or thick mucus cysts or those kind of specimens that there would be a primary assessment by the BMS who gets the sample in terms of preparation and decides, do you need to add a mucolytic agent or not before you then send it off to ThinPrep. So these are all things that could be adopted.
Thank you. I can see the questions are starting to tick in. So let's open up the floor a bit. And I can see a lot of them relate to how this might be adapted in local labs or workflows. And there's a question on workflow and efficiency here. In terms of the workflow, how did the digital experience of the participating pathologists compare to their usual practice? I remember from the talk, there was mentioned that this was relatively new for most of the participants. I'm sure there's a lot of learning there, but any feedback you could add to anyone else who is looking to adapt this?
Well, if I may answer that as well, and Adam, please feel free to add. I think now we have a little bit more, since the study, we have a little bit more digital experience, and it is a very easily adaptable modality, if you like. It has all the advantages and disadvantages that you would also find in histological preparations. I mean, it's the ease of annotation, it's the ease of showing cases around, the only sort of caveat is that you need to get a little bit more familiar with the size of the screen and with the how you actually screen these slides. But I think that is practice rather than anything else. The images were easily accessible. All you need is a good high-resolution screen. And I think what the study has very clearly shown that it is as good as light microscopy.
Thanks. And I don't want to put words into your mouth, but I guess one of the things you did mention was that this was slightly a scenario where people were asked to make a diagnosis, not refer to colleagues and friends, and so
it was slightly artificial. So in real life, I think obviously you would always show challenging cases around and discuss it with colleagues. Even ask for another preparation if you still have material. So there are ways to overcome the challenging cases, or sometimes you just have to accept that that's your limitation of the cytology preparation, and maybe you have to ask for a biopsy to formally assess the lesion that is there.
Thank you. And then sorry, Adam.
Just following up on that point, I think that the agreement analysis really illustrates that point, whereby we see a similar or even slightly lower agreement between light microscopy and light microscopy across pathologists than between digital and light for the same pathologist, really reiterating that point that these discrepant cases or challenging cases are challenging regardless of the modality you use. And it's not because we're using digital that we are seeing imperfect concordance. It's because cytology is difficult.
Completely right. So, and I think all ologies are difficult and require quite a bit of experience and interpretive knowledge, especially when the samples are so large as they are with cytology here, right? That said, it was quite interesting that you also included cervical cytology in this study, which we know has its own unique workflow. You alluded a little bit to it, that typically it would be done through a different pathway. Do you see bigger challenges with cervical cytology than with others, and how could that be adopted more efficiently in the workflow? Maybe two questions in one day.
Sure. I'll caveat my answers with the fact that neither Sabine nor I are cervical cytopathologists, but I'll give you my thoughts either way, having been involved earlier in my training and in this study. So cervical cytology is going through lots of changes in lots of ways, with primary HPV testing and so on, reducing the number of cases coming through. In the UK, I'm not sure how it is in other countries. As I mentioned, it's different. At least in our hospital, the non-gynecological cases are not screened by a biomedical scientist. They're primarily reported by the cytopathologist, whereas the gynae cytology cases are pre-screened and suspicious cells are marked. In this study, the reporting cytopathologists had to screen the slides. We did not have a BMS doing that for them. And so part of the challenge, I think, that we saw in the qualitative feedback coming through was the difficulty of doing that screening. And I think there are some differences with screening when looking at a big slide versus looking down the microscope, which would take adjustment. Also moving around the slide, the most efficient way of doing that. I think that what we'll see in cervical cytology in the digital space is two things. Probably one is the same pre-screening would happen as happens in light, and that would make things easier for our cytopathologists, not having to go through every single cell. And secondly, the introduction of AI. We're already seeing a number of studies being published of tools that do that pre-screening using artificial intelligence and highlight suspicious cells. Moving to a digital workflow enables you to adopt those AI-based methodologies, which are much more difficult, although possible with cameras and so on, with microscopy, but it really come to their fore when you're scanning the slides with high throughput scanning. And I think that's going to be the natural progression of this space, where slides are pre-screened by AI, suspicious cells for severe, moderate dyskaryosis, coilocytes and so on are marked, and the cytopathologist can validate and approve those diagnoses.
Thank you. And I can see there's loads of questions coming in, but I also note that we are at the top of the promised hour. So I'll begin to wrap this up a bit. Again, I hope I'm not putting words in your mouth, but as I understand, both of you, with the few caveats that are there and the adoption curve that needs to happen, you're both advocating for the use of digital within cytology, that we can definitely use scanners to accommodate for the digital workflow and incorporate cytology in that.
Yes, absolutely. I'm grateful for this study, because people always say, oh, cytology, it's not feasible to be scanned and so on. But after having been through these P cases, I feel actually much more confident, and actually also that we have shown that the concordance is excellent. So I would advocate the implementation of digital scanning for cytopathology. And as Adam alluded to the benefits, and with AI and so on, I think that could also be adopted to non-gynae cytology, because large cells are large cells, so AI should actually be able to pick those up. So like a pre-screening of non-gynae cytology specimens would be a huge advantage, and I think would fit very well into the workflow, and also progress the adaptation of digital pathology.
Thank you. Well, then maybe as a final thought from either of you or both, any last words on when digital cytology is really working at its best? How does a daily practice look like? How does daily life look?
Sabine?
Well, I think it would enhance the daily life of a cytopathologist. So, I think it's baby steps at first. I think people need to be getting familiar with the new imaging, and be comfortable with reporting. And I think then you have to look into bringing in AI and the rest of it. But I think, like anything that is new, it takes a little while to settle. And then I think the advantages that digital imaging has over light microscopy will be evident and exploited, like AI, like ease of showing cases around, even to people who sit not next to you, so to speak, but you can send cases away over the computer wise, and so have expert opinions at your fingertips. So I think it's a very good thing, and I would strongly advocate it, to implement it sooner rather than later. Adam, do you have any other remarks?
Yeah, so I agree. I agree with what you've said. I think that furthermore, it's probably it's only going to improve with time. The scanner technology is going to improve. The computational methods for extended focusing are going to improve. But really, the sooner we get used to working in this way and adapting our practice, the better.
Well, with those final words, then I'd like to thank the both of you for the time and for presenting the results in your study. And I'd like to thank the audience for joining us today. There's many questions we haven't answered, and there might be more that you think of after the webinar has ended. So please don't hold back. Keep on sharing them with us. We'll do our best to answer all of them by email or by text. And where we can't answer, we'll elicit the help of Dr. Levine and Dr. Pomplun. Thank you very much for joining us today. On behalf of Hamamatsu, see you later.